Hello?
Sir, hello? Sir?
Hello?
Yes, sir. Yes, sir. You're audible, sir.
Am I audible?
Yes, sir. You're audible, sir.
Right then. Okay.
Yes, sir. Yes, sir.
So now we have two good speakers for us. One is Dr. Meenakshisundaram. Are you ready, sir?
Yes, sir, I am very much.
Right, sir. Before I hand over the mic to Dr. Meenakshisundaram, I want to tell few words about him because he is Director of Neurology, SRM Institute of Medical Sciences, Chennai, and former professor and HOD of Neurology, Ramchandra Institute, Ramchandra University, Chennai, and he is the secretary of the Indian Academy of Neurology, secretary and founder member of MDSI, and winner of the CV Chari Prize and medal in Neurology 1996. He is the member of the MDS, Stiff Person Syndrome Disorders and Task Force. He is the organizing secretary of ECON 2015, MedScan 2016, and INCON 2017. His areas of interest are movement disorders, cerebellum, neuroophthalmology, and vertigo. So now he speaks on the eye science in ICU. Welcome, sir, Dr. Meenakshisundaram.
Thank you, sir. Thank you very much for the kind introduction, sir. I actually should first start by thanking the organizers, especially Dr. Balabhadra Venkatraju and Dr. Raviram Garu for inviting me over to do this talk. It has always been a pleasure, and I've been part of many AP Neurocons in the past. I'm missing the physical talk. Hopefully, we'll probably be able to do it sometime in the future, as early as possible. So this is the first slide as was requested by the organizers. Uh, so I start off by saying this is something I say, eye signs I see in the ICU. But we can also say the eye signs we all see in the ICU or the emergency room. Nowadays, the ER concept is coming up and it's more like an ICU. And this is an appeal to all of you. While you're free to take screenshots of slides with typed contents, I request you to not download or copy or record any of the patient videos. These are educative videos for which I do not have permission from the patients for social media usage, including webinars. Thank you very much for the understanding. Now, I'll start by showing this article that we wrote an invited review on eye science for the neurologists in the intensive care unit. It is available free. It is a polished journal of neurology and neurosurgery, Neurologia Neurochirurgica Polska. If you just type in eye science for the neurologist in the intensive care unit on Google, you will find it. So I'll go through with the aid of this article itself. So we had actually categorized the eye signs into three categories, two major categories. One was category 1, which is about exophthalmos, periorbital ecchymosis, conjunctival congestion, band keratopathies, KF rings, ptosis, and pupillary changes. And category 2, we divided into category 2A, which are the more common ones. We will go through them, so I'm not reading them out here. And category 2B, the commoner, the more ominous ones. So this is the way we classified them, and I will take you through with this. So we'll start with category 1. The usual spotted or observed. I'm sure all of you know this. You see the gaze deviation. If you're called into the ER or the ICU and you look at a patient, you want to know whether there is a gaze deviation. Is there a paralytic strabismus? And if there is nystagmus, what type? And then look for the ominous eye signs and rare but diagnostic signs. We'll always start off with the pupils because that's something that's very dear to our heart and we are very interested in it. So when you see pupils, you look at anisocoria, unequal pupils. So sometimes it's a doubt about whether the larger one is the abnormal one or the smaller one is the abnormal. It is very constricted on one side, you know very well. It's very dilated on one side, you will obviously know that the problem is in that pupil. But when they are only mildly dilated or mildly constricted, you're not sometimes sure which is the abnormal one. So if you see one large pupil, the problems could be third nerve palsy, iris problems, the unilateral eye drops, or AD's pupil. But you see a small pupil, definitely constricted on is Horner's syndrome, and then a small irregular pupil which reacts to accommodation but not to light is ARP. We all know that. When you see bilateral small pupils, They start thinking about pontine lesions in an appropriate patient, but we should also remember drugs, especially opiates. Horner syndrome, I'm not going to go to the details. All of you, I'm sure, know about this. It's a good lateralizing sign, but a very poor localizing sign because it starts right from the hypothalamic region up to the neck. So it could be anywhere. So you can't exactly localize, but you know it is an intrinsic brainstem lesion if it occurs with the other findings of a brainstem. That's how Horner's helps. So this is a nice article. This is actually one of the a very good article about evaluation of patient in coma. And you say the pupillary findings in comatose patients in a midbrain lesion, or let's start with the pupil. It's a mid-position fixed pupil. The lesion is probably the midbrain. If it's small and reactive, it's probably a diencephalic lesion here. It's a fixed dilated one. It's the third nerve lesion, fascicular or outside the brainstem too. If it's a large fixed one, you're looking at a tectal lesion. It's going to be like this. But it's pinpoint, you're looking at pontine lesions. We should always remember that patients with non-structural or metabolic coma have small reactive pupils. So this is a nice flow chart. If you see the pupil irregular, as I say, you see anisocoria. Then you want to know whether there is, one second, sorry. So if there is irregular, consider anatomic cause, example, trauma or sinus K, but it is not irregular. It's too small, consider Horner's. If it's not too small, then you look at light near dissociation. If it is there, think of Aedes pupil. If it is not there, and there is extraocular muscle involvement and or ptosis, consider oculomotor nerve palsy. If none of them are there, then you can be sure that this is a eye drop induced dilated pupil. So always look at these. This is a nice flow chart to follow if you're looking at the pupils. Now we go to the eye movements. I don't have to tell you, you're all neurologists and I'm sure there are trainees probably listening to this lecture, so put this slide for them. Look at eyes in primary position of gaze, always do. In the third nerve palsy, the eyes are often not just abducted but also down. So you should know that. And sixth nerve palsy, often eyes convergent. Unopposed medial rectus, look at the pupils, look for ptosis. A simple clue. There is a complex ophthalmoplegia. These are the common disorders. Dysthyroid eye disease, myasthenia gravis, and mitochondrial disorders. Three settings in which you would encounter complex ophthalmoplegia. Ptosis. So we talk about stroke and ptosis. Before we talk about stroke and ptosis, we talk about ptosis per se. The first thing that I would probably always look at a patient who has a ptosis is always test the orbicularis oculi. So if there is a problem in eye opening, then you should check eye closure. If both LPS, the palpebrae superioris, and orbicularis oculi are weak, it is going to be a disease of the muscle, the nerve, or the neuromuscular junction. You don't have to go looking. It is very rare unless you have a lesion which is involving, there is a pathology that is involving the third and the seventh nerves. You're not going to get a weakness of both these muscles. So it will be very rare for a lesion in the brainstem to be presenting. You won't need an imaging of the brain. This is something that would really help us. So there is stroke and unilateral ptosis. It could be as part of a central harness where you get meiosis. So that's what I said. Lesion could be anywhere. If it could be part of a third nerve nucleus or fascicular lesion. Unilateral or bilateral lesion of the third nerve can produce ptosis. That's something to remember because we know that LPS receives fibers from both it's from the caudal central nucleus, so you can easily develop ptosis with a single lesion. Supratentorial, where you can get eye opening apraxia actually. This is called cerebral ptosis. It occurs with large right hemispheric lesions and is a bad prognostic sign. It probably indicating that there is going to be herniation occurring in the patient, but this is more likely to be an apraxia rather than a third nerve lesion. A word about cavernous sinus thrombus. When you talk about complex eye movement problems, let us remember a few points about the cavernous sinus. We know that this is the cavernous sinus. This is where it is. And in what way is it different from other venous sinuses? What does it share? In what way is it different? The similarities, it's a dural venous sinus like the other sinuses. It is lined by endothelium. It lacks a muscular coat and it lacks valves. The differences are it's traversed by numerous trabeculae, which give it a sponge-like appearance. That's why it's called a cavernous sinus. The third, fourth, V1 and V2 are embedded in its lateral wall, while the sixth nerve and the internal carotid artery with its sympathetic plexus course through its lumen. The sixth lies free, and that's why one of the earliest nerves to be involved, cranial nerves to be involved in a cavernous sinus, would actually be the sixth nerve. So it's very important to remember that. So it's good to recap on this anatomy a little when we are examining a patient. We'll go on to category 2A. This is what I said. So here we're going to look at the eyes that are deviated, down and out eyes, down and in eyes, down and out with dilated pupil, down and out with spared pupils. So we talk about spared pupils and dilated pupil, the medical and the surgical causes, meaning diabetic. In diabetics, it is spared, and in aneurysmal bleeds, it is affected. So these are common points we say. But then there are others like the 1.5 syndrome, internuclear ophthalmoplegia, the lateral head turn, gaze preference, down and in eyes occurs the classic thalamic eyes. The wrong way eyes occur in medial thalamic, that can also occur with lateral medulla, skew deviation, upbeat nystagmus, downbeat nystagmus, and other types of nystagmus. If you look at a comatose patient, this is the commonest thing that a neurologist is asked to evaluate. And I certainly believe in looking at the eyes first up, and it definitely does help. The different causes of coma. You know that when there is coma, there is going to be involvement of the ARAS. There could be a diffuse hemispheric lesion like trauma, ischemia, hypoglycemia, infection, or drugs. That could be bilateral thalamic, as can happen with hemorrhage, especially a venous infarction, the deep venous thrombosis, a brainstem compression, supra or infradentorial mass lesions, or the brainstem itself getting affected, ischemia, hemorrhage, or drugs. So these are, please do read this article 2001 by Bateman. It's a very good article for evaluation of patients with coma. So the points to note would be looking at the resting position of the eyes. Look for spontaneous eye movements if the patient can do, or the involuntary ones that happens. On lifting the lids and releasing them, it would be good to observe tone and closure. It's very important. If the patient blinks, it's actually a good sign, either spontaneously or to bright light, sound, or menace. It tells you that yes, ARAS is responding to some stimulus, and this implies an intact pontine reticular formation. It's a nice sign. A prognosticating sign. I have many times used this to prognosticate patients. When carrying out corneal reflexes, it's important to observe the movement of the eyelid and the globe of the eye. If there is with an intact pons, eye closure will occur. You need the unit and intact pons for that. And with integrity of both pons and midbrain, the Bell's phenomenon will be present. If there is a Bell's phenomenon, then we know that the pons and midbrain reticular formation are intact. The reflex eye movement should always be performed. There's a clinical anatomical correlation. We have seen this before. I'll probably skip this slide. One of the commonest entities that we encounter is the posterior circulation stroke. When we talk about posterior circulation strokes, we're talking about three things primarily, of which two are important here: the vestibulo-ocular manifestations, vertigo and nystagmus, vertical diplopia, and the ocular tilt reaction. The visual manifestations can be diplopia, gaze deviation, ptosis, and homonymous hemianopia. Bilateral manifestations are more motor. So we'll talk about the first two specifically. We look at the vestibulo-ocular manifestations. We're going to be talking about vertigo and nystagmus, vertical diplopia, and the OTR, as I said. Is the nystagmus due to stroke? Is a pressing question for us as when we examine the patient. And nystagmus is in general central. If it is multidirectional, gaze evoked. If it is vertical, any pure vertical is definitely central. Pendular nystagmus or convergence retraction nystagmus is central. Dissociated nystagmus is the other name for INO. If it is not accompanied by vertigo and nausea, meaning that the peripheral vertigo is one of symptoms, while the central vertigo is more likely to be one of signs. If it is not improved by visual fixations, then in all likelihood, we're dealing with the central. The others that really do not help, positional can be peripheral or central, unless it's short and stereotyped as in DPPV. A conjugate horizontal or rotatory nystagmus does not really help. A transitory or persistent nystagmus does not really help. Whether it's transitory or persistent doesn't really help you. It can occur with vestibular neuritis, it can occur with a posterior circulation stroke. In nystagmus due to stroke, examination can lead to localization. If you have a convergence retraction nystagmus, an INO and rotatory, you're dealing with the midbrain lesion. If you have an INO and bobbing, you're probably dealing with the pons. If it imitates peripheral type and you still think it is central because you've done, I'm going to show you the hints. Dealing with medulla oblongata, the cerebellar lesions may imitate peripheral type, but they are multidirectional gaze evoked. The vertical diplopia of central origin. There is a central paresis of elevation or depression of one eye, as can happen with a fascicle of the third nerve getting involved in a midbrain lesion. Then it is a central paresis. But you can get an acquired vertical strabism, which is skewed. This is non-paralytic. The first thing is paralytic. The second one is non-paralytic. So it may be peripheral or central, but if you want to localize vertical diplopia in skew deviation, where is the lesion? So just remember this line. So it could be in the elevated eye, the side of the elevated eye, if it is higher in the brainstem. The lower you go, when you go come down to the medulla, it is going to be on the side of the depressed eye. So the other signs that the patient has, telling you whether it is midbrain or medullary lesion, will actually help you in localization. This by itself may not localize. For example, look at this patient with the midbrain lesion, which is on the right side. You can see that this eye is up, and that's what we're talking about. The lesion in this patient is here. Ocular tilt reaction consists of skew deviation, which is the non-paralytic deviation we talked about, the head lateroflexion, and ocular torsion, which all occur to the same side. And this is characterized by some visual tilt. Patient will tell us that they see everything tilted. And that visual tilt should make you think about ocular tilt reaction. So, for example, if this patient with a right lateral medullary stroke due to a vertebral artery occlusion turned out to had presented with OTR and subjective visual vertical. Now, this is an article that came in 2009 and saying the way that clinically we evaluate patients with, even though we talk a lot about interventions and everything, this is really important. If we're going to decide on whether you're going to thrombolize a patient, for example, a patient is presented with an acute vestibular syndrome. So 3-step bedside oculomotor examination, which is shown to be more sensitive than early MRI DWI. So what it produces, the skew predicts brainstem involvement in acute vestibular syndrome and can identify stroke when there is an abnormal head impulse test, falsely suggesting a peripheral lesion. So, so basically what it means, we are doing the OCR, meaning that the pathway should be intact. The pathway is affected, which is more likely to happen in a peripheral. But please remember the caveat that if it is normal, then it tells you it's probably a central cause. But if it is abnormal, you should know that it could still be in the brainstem where the nerve enters the brain, meaning that with a lesion at the pontomedullary junction, you can still have an abnormal thing. So a normal head impulse test would suggest that it is a central lesion. It definitely appears. So this 3-step bedside oculomotor exam is called the HINTS, head impulse, nystagmus, test of skew. I'm just showing this. This is not a VNG. This was a clinical recording. Okay, so that was to show that it was a normal OCR that the patient had. He had presented with an acute vestibular syndrome and had some nystagmus. So he had a stroke. Hints to infarct, and this is a nice thing. So the findings that suggest a benign etiology are unidirectional horizontal torsional nystagmus with a contralesional post phase, normal vertical ocular alignment, meaning that there is no skew deviation, and an abnormal head impulse test, meaning that this is peripheral. This is little benign, but it is definitely more symptomatic. Findings that suggest a dangerous etiology. Dangerous is meaning that this is central, you're looking at an acute stroke or something. Yes, direction changing nystagmus, abnormal, the skew deviation, normal head impulse test, and presence of unilateral sensory hearing loss. This is called HINTS plus. If somebody has sensory neural hearing loss with prolonged vertigo, along with the others, you're going to be talking about HINTS plus. So HINTS is what we discuss. Infarct is impulse negative, fast phase, alternating. Fast phase alternates side changing, and there is refixation on cover test. So this is called infarct. So hints to infarct. So there's the next acronym that is comment. We're talking about visual manifestation. This is something that I'm sure most of you know. Vertical diplopia and gaze paresis, horizontal, the wrong way eyes, ptosis and homonymous defects. Remember that when you see what looks like an abduction problem, what looks like an abduction palsy, you could have a fascicular sixth as in Pons, or you could have a pseudo sixth where there is actually hyperconvergence, convergence spasms as can occur in dorsal midbrain, or there is decreased adduction due to an INO. So depending upon what the patient has, the localization changes. So it's important to first make sure that we are dealing with, because even in patient, this is, if you can look at this patient, he is obviously trying to adduct, and this is not going in while the other eye is adducting well. So this is a right sixth, it's not, I'm sorry, it's not going out while the left eye is adducting. So this is right sixth nerve. But if you do the OCR, you will make out that this is a nerve palsy. So this all of us know that in a central lesion, patient looks at his lesion, contralateral looks at his hemiparesis. But then you should know that sometimes wrong way eye deviation can occur. And when it comes to the medulla again, there is this in lateral medullary syndrome, what is called ipsipulsion. So they can again look at this, patient can look at his or her lesion. A point to note, if a patient has homonymous hemianopia, then look at the OKN in a conscious and cooperative patient. The lesion, when the OKN is preserved, the lesion is in the occipital lobe, meaning that it is abnormal in parietal lesions. If a patient has a hemiplegia, hemianesthesia, a homonymous hemianopia, but does not have aphasia or hemineglect or anosognosia, then you should think about anterior parietal artery syndrome. So this is, otherwise the differential diagnosis is between an MCA stem and an anterior parietal artery. You look at the hemispheric signs, they're not there. It will be very important actually when you're planning thrombolysis or looking at an endovascular treatment in these days. This I would skip because this is not about eye science, so I'm going to skip these. Just to know that the thalamus, remember that the thalamus is a great imitator and it can lead on to vertical gaze paresis and visual field defects. So as a treating neurologist, why should I know at all where the brain suffers? It's a posterior circulation stroke and you're going to treat the same. It's not like that. It's very important because, a proximal lesion like Wallenberg, plus or minus cerebellar, plus or minus medullary, is a vertebral artery disease, a bilateral vertebral artery disease many times. A mid-basilar is a locked-in syndrome is the presentation. It is due to local atherosclerosis or embolism. While a distal one, the top of the basilar, is typically embolic and since proximal is also cardiac. So this is important. It is etiologically important to be doing a good evaluation of the eyes when you examine the patient. Quickly through brainstem eye movement disorder syndromes, we know the Weber's syndrome, which is commonly known. We look at the Perrinot syndrome, which is also called Sylvian aqueduct syndrome, pretectal syndrome, the Kobus-Salas-Elschnig syndrome, or the dorsal midbrain syndrome. Let's look at this patient.
Take picture or video? No, video, man. Video only you're taking? Video. Okay. Yeah. Now you can just order, commander. Ma, மேல பாக்குறீங்களா? Right.
I hope you're able to see the eyes converging, retracting. That's what this lady had. And so this was a convergence retraction nystagmus. Some people do not like the word nystagmus to be used here because it is not exactly one that has a fast and a slow pace. So Perrinot syndrome is a lesion of the posterior commissure. It causes compression. It's usually a penial mass, but it can occur with the midbrain infarction, which is posterior. This is where the dorsal midbrain syndrome is. Its port absent upgaze occurs. In the convergence retraction nystagmus, Collier's sign and setting sun sign or other signs that are seen in this syndrome. Now, when you see this artery, I was listening to Dr. Netravati in the morning and she was showing an MRI like this. When you see lesions like this, there are a lot of differential diagnoses, but this man had an artery of Percheron infarction. Now, for patients who had an artery of Percheron infarction, we'll look at his eyes.
இங்க பாருங்க, இந்த சைடுல பாருங்க, இந்த சைடுல பாருங்க, இந்த சைடுல பாருங்க, இந்த சைடுல மேல மேல பாருங்க.
So this man had actually come unconscious, literally, and he recovered consciousness pretty soon. That's one of the characteristics of an artery of Percheron syndrome. And then as he recovered, this is about the fourth or fifth day, and you can see that he is conscious but has difficulties in up gaze.
இங்க பாருங்க.
I'll skip this. Okay. So when you see an MRI like this, or and with other features like this, what are we likely to think of? We're likely to think of Wernicke's encephalopathy in a patient who was confused, who has eye movement abnormalities, and shows MRI changes. Then we know that Wernicke's encephalopathy is caused by thiamine deficiency, and the triad is confusion, cerebral ataxia, and ophthalmoparesis, paralysis of one or more ocular muscles, petechial hemorrhages of small vessels in the mammillary bodies, which are associated with necrosis and loss of neurons, causing shrinkage and gliosis. I'm sorry, something went wrong. Sorry, something is wrong. Okay. So this is operational criteria called Kane criteria from 1997. The classic triad is only seen only 22%. Crane criteria is seen in 85%. So here the criteria included dietary deficiency, oculomotor abnormalities. So the one that was added was dietary deficiency. You can look at the BMI, a history of impaired dietary intake, and include alcohol and impaired dietary intake as part of it. So this is a DD, just on one point, that metronidazole can present like a Wernicke's encephalopathy because metronidazole is converted to a thiamine analog and causes vitamin B1 antagonism. The others include the artery percheron, as we have seen, deep CVT, ADEM, CMV encephalitis, variant CGD, primary lymphoma, and now we must add anti-MOG antibody. I'm sorry, I didn't add that here. So when a patient presents vertical gaze palsy, the localization, there is bilateral vertical gaze center or RAMLF lesion is going to be a downsized saccadic palsy as paralysis of both upward and downward saccades. Bilateral pretectal lesions or midline lesions of the posterior commissure, there is paralysis of only upward gaze. Remember that posterior commissure. Unilateral lesions of the RAMLF, which is the vertical gaze center, the mild defects in vertical saccades, combined up and down gaze palsies. While unilateral mesencephalic lesions can cause bilateral up gaze palsy, palsy of upward and downward saccades, and there will also be impairment of pursuit and vestibular movement. That is when we start thinking about mesencephalic lesions. I'm not going to go through this because it's known. We will talk about 1.5 because one of the is always a fascinating thing because it is there in Hutchison and Hunter, which we studied during our first clinical. And from then on, we have been hearing about it. I'm not going to really tell you what 1.5 is. I'm sure all of you know this. But we must know there are 3 possibilities to account for an ipsilateral horizontal gaze palsy, which could be the ipsilateral PPRF, ipsilateral abducent nucleus alone, or both of them getting affected. So it could be the localization value is a little different. You must know about abducent nucleus because it's something that's often overlooked. The abducent nucleus doesn't contain only the motor neurons for the sixth nerve. It also contains internuclear neurons, meaning that if you have a lesion of the abducent nucleus, you can actually produce 1.5 syndrome. But that's just to tell you graphically how it works. So how do we differentiate? Because commonly we say 1.5 syndrome is PPRF plus MLF. How do you differentiate whether it is a sixth nerve nucleus lesion or a PPRF plus MLF lesion? One is the involvement of seventh nerve, which is almost invariably involved because it loops around the sixth nucleus. If it is there, it helps you. And also in primary position, because the sixth nucleus is involved, the ipsilateral eye is mildly adducted. Well, it's not the case in a 1.5 syndrome due to PPRF and MLF. Esotropia and seventh nerve involvement will be the clinical clue to tell you exactly where the lesion is. The pathogenesis, this is for another time. We probably won't have much time because we have some more videos to see. But there are a few clinical points to know about INO. It is a definite sign of intrinsic brainstem lesion, but we should be aware of the rare pseudo-INO, means which can occur in myasthenia gravis. The site of involvement in the brainstem can only be surmised with the associative features, much like how we talked about Horner's syndrome. The INO and Horner's are signs of intrinsic brainstem lesion, but they can't really localize within the brainstem. You'll have to depend on other signs. And there is always a degree of skew deviation associated with INO because INO not only connects the ocular motor nuclei, but also the vestibular pathway. So there will always be some skew deviation. Let's see this patient.
மேல பாருங்க, கீழே இங்க பாருங்க, நேரா பாருங்க, பாருங்க, லெஃப்ட்ல பாருங்க, பாருங்க.
So that's a classic INO, the internuclear ophthalmoplegia.
இந்த பக்கம் பாருங்கம்மா, இந்த பக்கம் பாருங்க, தலையாடு.
Now here you would notice immediately that there is a left facial lag and she is not blinking well on the left side.
கண்ணு மட்டும் வந்து பாருங்க. ஓகே, இந்த பக்கம். இப்போ அந்த பக்கம் பாருங்க, இந்த பக்கம், வலது பக்கம், இந்த பக்கம், அந்த பக்கம் பாருங்க. இப்போ சரி, இப்போ என்னோட வரல மட்டும் பார்த்துட்டே இருங்க. சரி.
So this was a lady who turned out to have a lesion at the 6th nerve nucleus, and that's what she had. So if you actually look at the MRI in your mind, it's actually a very good exercise that any clinician would love to do. I definitely love to do. If you look at a clinical thing and then say, this is where I think in the pons or the midbrain the lesion is, and then look at the MRI, you will many times be surprised of how perfect you are, how correct you are with your localization, and you will always get thrilled. I think these are small thrills that will take us through the day when we see hundreds of patients.
இந்த பக்கம் பாருங்கம்மா, தலையாட்ட கூடாது. இந்த பக்கம் பாருங்க. Very good. இந்த பக்கம் பாருங்க.
Right. So as she looks to either side, here it's a reverse that's happening. The abduction is lagging. Abduction is not happening while the adducting eye is showing a nystagmus. So this is called reverse INO. Supposed to be a lesion in the posterior part, the part that of the pons where the connection between the two 6th nerve nucleus is affected. Now this is a straightforward diagnosis. I am sure when you see a patient in the ICU who is on a Ryle's tube and has one eye that is one palpebral fissure that is smaller, your first diagnosis is lateral medullary syndrome. Okay, I'll run the video so that.
வரல பாருங்க, இந்த பக்கம் பாருங்க.
Right. So we can talk about lateral medullary syndrome itself for half an hour. It's a neuro-ophthalmologist's delight. And there are so many other findings that you can make out in lateral medullary syndrome. The one feature that we need to remember is that there is a lesion of the vestibular and the cerebellar pathways. So you will have combined eye signs in these patients. So the spectrum actually, this is a nice article that came way before in 1994. But there are many ways clinically where you can think whether it is rostral or distal if you look at the clinical findings. But there are some nice findings that may be worth looking at in a patient with lateral medullary. Here we are showing another patient. Please look at this patient. Right. So when you open the eyes, you could see that his eyes were pulled to one side, and that's called pulsion, pulling to one side. Ipsipulsion and contrapulsion can occur. Ipsipulsion is a characteristic feature of lateral medullary. See that this palpebral fissure is smaller and there is pulling. So when I actually ask the patient to look down, look up, his eye cannot go straight like that. It will be pulled to one side. So there is what we call round the house sign. So when you have round the house sign, it only means that I'll probably go forward so I show that sign alone.
திருப்பாதீங்க, இந்த வரல பாருங்க, அந்த பக்கம் பாருங்க. இல்ல, தலையாட்டாதீங்க சார். அது முடியல சார். அது ட்ரை பண்ணுங்க, தலை கழுத்து அசைக்காம ட்ரை பண்ணுங்க. இங்க பாருங்க, நேரா பாருங்க, நேரா பாருங்க. ரைட், குட். இது பார்த்துட்டே இருங்க. இந்த வரல பாருங்க, கண்ணை உருட்டி. இந்த பக்கம் பாருங்க,
ரைட் சைடில் பாருங்க, இந்த பக்கம் பாருங்க, இந்த பக்கம் பாருங்க. சரி, நேரா பாருங்க, விரல பார்த்துட்டே இருங்க. இங்க பாருங்க, விரல பாருங்க, விரல பாருங்க, விரல பார்த்துட்டே இருங்க. அந்த பக்கம் பாருங்க. So as he looks down, it's a long video, so I'll skip it in the interest of time. So my own tip when I see a patient is that, if there's somebody has all these yeses, swallowing difficulty, squinting eyes, same side ataxia, side changing nystagmus, slants while sitting, and has a sensory impairment, the pain and temperature which is crossed, it's a syndrome of yeses, it's spica syndrome. And the patient sees double, is deaf on one side, is dizzy, and has deviation of mangle of the mouth. It's called 4Ds. That's ICA syndrome. So these are good clues to know. So double deaf, dizzy, deviated is ICA syndrome. So the last part, these are some ominous signs, category 2B. There are a lot of signs. There are some of them that are not also ominous, like Orbicularis, but there are many like ping pong eyes, roving eyes, ocular bobbing, which are all pretty ominous. So this is a patient, just quickly. Right. So you must have made the diagnosis by now. Right. So you saw that chaotic movement which is happening in multiple planes. This patient had obscureness. So when you look at these movements, you can look at saccadic intrusions and oscillations. If there is with the intersaccadic interval, movement occurs, there is a small interval, then the next movement occurs, there are some. Without an saccadic interval, you have obscureness, ocular flutter, voluntary nystagmus of flutter, and microsaccadic oscillations. But this is obscureness. A quick, the anatomical basis of obscureness, autopsy studies have shown Purkinje cell loss and dentate demyelination in such patients. This might be a good flow chart for obscureness. Look for myoclonus. You must have at least 3 of the following before you call obscureness, myoclonus. Obscureness, myoclonus, ataxia, behavioral change. Then you have to necessarily look for infection, and you have to look for occult malignancies. In children, search for neuroblastoma. Investigation definitely depends on the age and clinical suspicion. Now look at this patient.
சரி, இது வந்து சண்டே அன்னைக்கு 3 வேளை சாப்பிட்டீங்க மாத்திரை. அதுக்கப்புறம் நேத்து 2 வேளை சாப்பிட்டீங்க. அது காலையிலயும் மத்தியானம்.
Right. So her eyes go up like this, and she's a conscious patient in the OPD, and this is Orbicularis. What did she take? She was on levosulfide. That's in the last part of the video. Now we're looking at other signs, the more ominous ones. Right. So what was that movement where the eye just goes up, goes down like that fast and comes up slowly? That's bobbing. So ocular bobbing, if you actually see this patient, how she had, he started off by having a unilateral bobbing in the first part, then starts having both. So that can be unilateral ocular bobbing also, but it could be, it is primarily a lesion of the pons, but it is not essentially only a pontine lesion. So this is what the patient does. We'll run through this video quickly.
So one eye. Now only one eye is bobbing, not both. And now it's only one eye. Only the right eye bobbing, and you see both eyes.
So you saw that sometimes it's only one eye, sometimes it's both eyes. So ocular bobbing can present that way. It's very important to remember that. And this is what this lady had. And this lady had a pontine hemorrhage. And see that the lesion is slightly more on the right side. That probably explains why she has more bobbing on the right side, or more frequently on the right side. Look at this. Look at this lady. Her eyes are already deviated down, but she still has a little skew deviation. Right. So she also has an ocular bobbing, but her eyes are also downward deviation. So there's a downward deviation. You will think that there is a lesion not only in the pons but also the midbrain. But it's always good when you're examining the patient to look at them for some time at least 2 minutes, observe the eyes as to whether they move, wait for the eyes to move and look for the eyes for at least 2 minutes, and also do the oculocephalic reflex that can bring out movements that may not be otherwise immediately visible to the eyes. So this lady, as I said, had a pontine lesion predominantly, is an infarct, but it also had a midbrain lesion, which explains why her eyes were downward deviated too. So this is an article from way back where itself they said that there are multiple, the clinical spectrum can come anything. About bobbing, which is a fast movement downward. We think it's like dipping a ball inside water. If you take a table tennis ball, a ping pong ball, push it inside water. You go slow, leave it, comes up fast. That's why it's called dipping. So ocular bobbing and dipping, but the same thing can also occur. The and in the upward direction, it's called reverse ocular bobbing, going up fast, coming down slow. Reverse ocular dipping, which is going up slow and coming down fast. All of them can. This is this patient. There is some noise. Somebody.
We have the symposium, sir. Next, can we make it fast, sir?
Let's see. Yeah, just see the eyes. This is a patient taken from the head end. So what you're seeing is actually reverse. See that there is a slow upward deviation, comes back to the line. So this is reverse ocular dipping, and this is actually seen in some encephalitis, like AIDS encephalitis and other things. And ocular bobbing, again quoting a very old article, the myth, I just showed this for this one. The myth that this sign is specific for intrapontine destruction has to be abandoned. It's not just the pons, it is definitely a pointer to pons involvement. It can occur with other lesions.
సార్ అది మనం లేట్ రన్ అవుతున్నాం సార్. యాక్చువల్గా మనం లేట్ రన్ అవుతున్నాం సార్. ఆల్మోస్ట్ 40 minutes లేట్ రన్ అవుతున్నాం సార్.
Somebody needs to mute the others, please.
కొద్దిగా ఫాస్ట్
అయిపోతుంది.
సార్. ఎస్ సార్.
Others, please. Can I request fine Neelima? So we are talking about roving eye movements, ping-pong gaze, and periodic alternating nystagmus. So roving eye movements are slow ocular conjugate deviations which occur in random directions. So these are slow ones. I just keep scrolling that way, they conjugate. Well, ping-pong, it's about playing table tennis. It's a slow, repetitive, rhythmic back and forth, like somebody serving, somebody returning. These are again horizontal, but these are repetitive and these are rhythmic. So you see the ping-pong, like how they play. Both indicate intact operability function in the brainstem, but there is some extraneous problem that is causing the patient to be unconscious. So these are mostly seen in unconscious patients. I'm going to, this is the last one almost. So when you see this is a patient with a periodic alternating nystagmus. Most of the cases, I have now seen about 7 cases. All of them have been with hypoxic encephalopathy or with severe strokes. And know that PAN, periodic alternating nystagmus, pathology at nodulus. That's what it stands for. This is one reason why I said you must examine a patient for quite some time. It's not uncommon for the PG to present that the postgraduate to be telling the sir, when I came in the morning, the eyes were looking to the right. And by the time the chief comes for rounds, it is to the left. So what happens? It is changing. Look at this. It's actually a 5-minute recording. I don't have time to run the whole thing, so I'm going to show you quickly.
We are running late, sir.
Fine. I thought I'm finishing in time.
Yeah.
We started pretty late. Right. So this is what happens. After some time, it goes to the right side. So this is important to look at in a patient. If you want to examine the patient, please examine the patient for at least 2 minutes to 3 minutes before you know about these eye movements. I think I'll stop here. I'll stop here saying become a member of the Indian Academy